Hello, welcome to the Spinal Cord Injury Forum. I'm Chuck Bombardier, a rehabilitation psychologist at the University of Washington in the Department of Rehabilitation Medicine. I'm the director of the Northwest Regional Spinal Cord Injury Model System here at the University of Washington. The forums and the video recordings that we make and our online media content are made possible by a grant from the National Institute on Disability and Rehabilitation Research. Tonight we're very pleased to welcome two of our finest faculty members from the University of Washington Department of Rehab Medicine to talk with you about pain and spinal cord injury. Dr. Debbie Crane is a rehabilitation physician at Harborview Medical Center, and she'll discuss medical approaches to pain management. Dr. Dawn Eady is a rehabilitation psychologist in our department, and she'll be talking about self-management strategies for managing pain. After the presentations are completed, we'll open things up for questions and invite you all to participate at that point. So I'd like to first welcome Dr. Crane.
Okay, so I'll be talking kind of more about the medical side of pain management and then turn things over to Dr. Eady for some of the more rehabilitation and psychologically based management strategies. So to start with, pain is very common, unfortunately. Statistics kind of vary, but generally it's thought that about 4 out of 5 people with spinal cord injury report significant chronic pain. Of those, about a third report that the pain actually interferes with their quality of life and their daily activities. So there's a lot of different types of pain that exist, and I'll review those different types and some of the characteristics that help define those different types. And then I think it's important to remember that function may be limited both by pain, but often a lot of the side effects for some of our different management strategies can limit folks' function as well. So that's always a situation that makes pain management even more challenging. So the way I kind of think about it, and a lot of the different experts on pain management think about it, is that there's basically 3 types of pain for folks with spinal cord injury. One is neuropathic pain. That typically people describe as pins and needles pain, burning pain, stabbing. It's typically, it can typically be at the level of injury, so where your sensation or your strength changes, above the level of injury or below the level of injury. There's not usually a specific trigger that brings on the pain. It's often for folks pretty constant. It may vary a little bit, but it usually is kind of there and doesn't fluctuate all that much. Then there's musculoskeletal pain. That's typically more of a dull or achy pain. It's typically above your level of injury, so the muscles and areas of your body that are innervated normally or have not been affected by your spinal cord injury. And this type of pain is usually affected more with movement, so there's usually specific triggers that can bring this on. And then visceral pain is often described as kind of achy pain. It's often a little bit more vague, particularly if you don't have normal sensation in your abdominal area. So it's often caused by some sort of abdominal irritation. It can be kidney stones, bladder stones, gallstones, a gastrointestinal kind of virus. It's usually hard for folks to really pinpoint, but it can be caused by a lot of different things. The last 2 types, musculoskeletal and visceral pain, here at the bottom, are sometimes referred to as nociceptive pain, and that basically means that the peripheral nerve endings that are intact are actually being irritated by some sort of noxious or irritating stimulus. The neuropathic pain is not so much that way, but the nociceptive is actually receiving true pain signals. So I'll talk a little bit more specifically about each of those different types, and then I'll move on to treatment. So musculoskeletal pain, unfortunately, affects a lot of folks' bodies. So back and neck pain can be very common. It's thought, although some of the research is a little bit contradictory with different studies, but it's thought that poor posture can contribute to back or neck pain. So folks with spinal cord injury will not uncommonly develop scoliosis or what's called kyphosis, which is a little bit of kind of a hunchback. And the data has been a little bit inconsistent, but the thinking basically is that abnormal posture will be uncomfortable over time. The other thing that can sometimes happen is folks will get muscle imbalances. So if your trunk, your kind of abdominal and back area, isn't innervated completely normally and you don't have full strength there, you're not able to use your core muscles to keep your posture upright. So folks will sometimes use kind of their shoulder muscles in a way that they weren't necessarily meant to, and sometimes that muscle imbalance can cause some discomfort. Shoulder pain is super common, and it's often thought that kind of the overuse that folks will do if they're wheelchair users or if they're walking but using a walker or a cane or crutches or that type of thing, they're putting a lot of strain on their upper body that wasn't necessarily kind of what the upper body was designed to do. And over time, people can develop arthritis of their shoulder joints. They can develop rotator cuff tears and different trouble in that way. Elbow pain is another pretty common situation. There's lots of things that can contribute to elbow pain. One thing is that folks, again, if their trunk isn't completely innervated, they'll often be relying on leaning on their elbows to hold themselves upright. So over time, leaning on your elbows can cause a bursitis. You can get arthritis of your elbows over time. And then also something to just kind of keep in mind is all of us have our ulnar nerve, which innervates a lot of our hand, that runs kind of on the inside part of our elbow. And if that gets pinched over time, you could also be developing an ulnar nerve injury. And then wrist and hand pain also can be somewhat common. So a lot of research has shown that folks with spinal cord injury and really all people that use wheelchairs put a lot of strain on their carpal tunnel. So your carpal tunnel is the area on the front part of your wrist where your median nerve runs through. And it's thought that extremes of wrist position, so extension or flexion, will put an additional strain on that area. So carpal tunnel syndrome becomes quite common for folks that use wheelchairs for a long time. So it's important in that way, and you know, this is kind of a broad topic, so I'm not going to cover any one specific thing in complete depth, but it's important to make sure that you're using good biomechanics and you know, all the things that your physical therapists and occupational therapists teach you are really for a reason, to try to keep all your different joints and areas of your body as healthy as possible. So as far as musculoskeletal pain, this is just some of the different options for treatment, and a lot of these things kind of overlap. So physical therapy, and you know, depending on the setting and who your provider is, sometimes occupational therapy as well, can be really important and often kind of overlap pretty significantly with all these different things on this side of the wheel here. So physical therapy, occupational therapists can help design a good exercise program for you. Certainly kind of looking at what your activities are. So if you are in a situation where you're performing 12 transfers a day while you do errands all over town, looking at perhaps there's a way you could kind of consolidate some of your activities and do a few less transfers. You'll be putting some lower amounts of strain on your body. So that can be important. Making sure that your wheelchair, so getting a good wheelchair evaluation, making sure that that's really optimally fit to you. When you think about you're spending your whole day, pretty much all your waking hours often in a wheelchair, making sure it fits you right, that it's really optimizing your posture and optimizing what your mechanics are with your upper body if you're propelling your chair with your arms is very important. I guess I'll touch on weight control first. I think it's just important, and it's certainly hard for all people, and if you're limited in what kind of activities you can do, it makes it even harder. But the less weight that you're having to haul around, the less strain that you're putting on your upper body. So that's something to just keep in mind as much as possible. Surgery for some folks will be an option. There's been a few different studies looking at the outcomes of surgery for folks who've had rotator cuff injuries, who have spinal cord injury. One study was done by Dr. Goldstein, who some of you may be pretty familiar with. He's been both at Harborview and the VA hospital as well. So that study was pretty small. I think it only involved about 5 patients, and some of them had 2 rotator cuff surgeries. It showed, unfortunately, that the rotator cuff surgery didn't dramatically improve people's symptoms. Another study done by somebody not associated with the University of Washington, I don't remember where that provider worked, but they showed that of, I think 7 or 8 patients who had rotator cuff surgery, or I'm sorry, 8 patients had the rotator cuff surgery, 7 of those had significant improvement in their symptoms. So the jury's kind of out of how much rotator cuff surgery or different shoulder surgeries will help folks, but it remains an option for some people. Injections, so folks will sometimes get cortisone shots or corticosteroid injections, and those can sometimes be helpful for pain management. And then, of course, medications, which I'll talk about in more depth as I move along. So a few things to just consider for people with spinal cord injury when we're thinking about management of musculoskeletal pain. So the first thing is, I already kind of mentioned, if you're using a manual wheelchair, or really any wheelchair, but particularly with musculoskeletal pain, if you're using a manual wheelchair, the fit really becomes vitally important. Making sure that your angle, your elbow angle is appropriate, that your shoulders are in the right position, that your pelvis and your back are optimally supported really is very essential. One thing to think about if you do proceed with a cortisone shot or a corticosteroid injection is that when you have a steroid shot, you're at a little bit more risk of tendon rupture unless you rest your limb. So it's important if your doctor suggests, well, let's do you have some bursitis in your shoulder, let's do an injection, to really think about, are you going to immediately leave that clinic and roll, push your way back to your car and then transfer into the car and drag your wheelchair in and then transfer out when you get home and drag the wheelchair out and transfer over to, so thinking about how you might rest your upper limb after an injection is really important. Kind of in the same line of thinking, surgery, for some people, some of the surgeries, like a carpal tunnel syndrome surgery, is a relatively minor surgery, but if you are using your chair or using your upper limbs to get yourself around, putting weight through your arms right after surgery isn't usually accepted. So you usually need to go on rest somewhere, depending on what surgery you have, somewhere between about 3 weeks and sometimes up to 6 months if you have a really major upper limb surgery. So sometimes that'll mean going to a nursing facility while you heal up, because depending on your situation at home, you may be completely independent normally, but if you take one arm out of the situation, now you really need almost full-time help. So just kind of keeping that in mind, and in some situations I think the actual person with the spinal cord injury is much more an expert on spinal cord injury than the surgeon they may be seeing. So advocating for yourself that this isn't going to be a same-day procedure and you're just going to go home is certainly important. And then something that people usually are pretty hesitant to consider, but is possibly considering a transition to a power wheelchair. And this can really be for folks that walk or ambulate, or folks that use manual wheelchairs. Over time, years and years of use, stuff kind of wears out, and at some point, sometimes people are able to be much more active and live a much more pain-free life if they do transition to a power wheelchair. That's usually kind of an idea of last resort for most folks, but sometimes something to consider. And some guidelines will say that if you do actually go through surgery for an upper limb issue or a rotator cuff, that then you really should use a power chair for the future because you're at more risk of upper limb injury. And then lastly, as far as types of pain, I'll talk a little bit about visceral pain. So as I said, it's usually located in the abdomen. For folks that don't have normal sensation in that area, it can be kind of hard to fully localize, but they'll often describe it as dull, achy, or crampy. You may have associated other symptoms like a fever or nausea, and usual things that will contribute to this would be things like constipation, kidney stone, ulcers, gallstones, or appendicitis. Typically, this would be more of a transient or a pain that would come and go. It wouldn't necessarily typically be something that you would deal with all the time. And then neuropathic pain. So I think for most people with spinal cord injury, they're pretty familiar with this, and often this is what would bring them to this kind of presentation. But I think of neuropathic pain as kind of a crummy cell phone connection. That before your spinal cord injury, the cell phone connection was crystal clear, the signals went through normally, and everything was working great. After the spinal cord injury, there's still signals getting through, but now it's kind of the, can you hear me now? Can you hear me now? There's some signals getting through, but they're not very organized and they're not going through quite right. So folks will not uncommonly complain of numbness, tingling, burning, stabbing, fire. People probably have their own terms, but those are probably the most common. So, and from here on out, I'll kind of focus more on neuropathic pain management. Neuropathic pain management is really kind of multimodal, and that's what I'm kind of attempting to show with this diagram. So I think one thing that's very important is to try to identify if there's any medical complications first. I mentioned that sometimes people will get injuries to their elbow and might have an ulnar nerve injury, or carpal tunnel syndrome is an injury to your median nerve in your wrist. So you want to work with your provider to see, do you have some other injury that's contributing to some of that pins and needles type pain that you're having, or is this kind of the spinal cord injury pain that you've had since basically the day that you got injured? Other things that could potentially cause a change in your nerve pain might be a cyst-like structure in your spinal cord. Sometimes if the nerves are kind of scarred down in your spinal cord, that can contribute to pain. So you do want to make sure, particularly if there's been any change in your pain, that you're getting that sort of checked out. Modalities, and by that I mean things like heat and ice or a TENS unit are important. So That I'll speak to a bit more. Medications often are kind of the main thing that people will rely on, so I'll go through a lot of different medication options. I'll touch on some different alternative therapies. I'm not an expert in alternative medicine or complementary medicine, but I will touch on a few different things. And then Dr. Edie will primarily talk more about the psychological intervention, so I'll leave that to her. So this is basically the different, and hopefully people can read it on its side, but this is the different major classes of medications that we'll typically use for nerve pain. So acetaminophen is the fancy name for Tylenol. I put that on there particularly because I think sometimes people overlook it. People think, oh, if I can get it over the counter and it's just Tylenol, it can't really be doing much. But in fact, for a lot of people, it can be pretty helpful. The other thing it can really do is it can help some of these other medications work better. So often if you combine Tylenol with NSAIDs, which are anti-inflammatory medicines, you'll get kind of a synergistic or a extra strong effect. If you combine Tylenol with opioids or narcotic medicines, things like morphine, oxycodone, you'll often also get kind of an extra better effect. So those are good things to think about. Antidepressants, and there's a few different types that I'll talk about, are increasingly being used for nerve pain. Anticonvulsants, things like gabapentin and Lyrica, which folks are probably fairly familiar with, are used quite a bit. NSAIDs, or non-steroidal anti-inflammatory drugs, are not always used tremendously frequently for nerve pain, but can be helpful as kind of part of a different modality approach. I'll talk about opioids more, and then some different topical options as well. So as I said, antidepressants are becoming increasingly commonly used for nerve pain. They obviously can have effects and benefits for mood, but often they're prescribed really with the goal of helping nerve pain. There's two major classes that we'll use for nerve pain. There's more different classes of antidepressants than just these two, but these are the two that are most commonly used for nerve pain. So TCAs, or tricyclic antidepressants, the most common of those that we use for nerve pain are amitriptyline and nortriptyline. Major side effects with those guys are dry mouth, and for some folks it's really pretty intolerable. Other things that will sometimes happen with the TCAs is constipation, which might be hard to tell if it's really affecting your bowel if you're already dealing with neurogenic bowel, but for some folks it'll just make it extra hard to really get things moving. And urinary retention. So if you're managing your bladder with a catheter, urinary retention isn't that big of a deal, but if you're able to void or urinate to some extent, the TCAs may kind of put you over the edge that you no longer can void or urinate any longer. So for folks that are able to urinate, that sometimes will not work out so well. But otherwise, it's a pretty safe medication and is really very effective for a lot of people. The SNRIs, or they're also known as serotonin norepinephrine reuptake inhibitors, SNRIs, a little easier to remember probably, are a little bit newer, but being used quite a bit and being studied quite a bit as well. So venlafaxine is the generic name, Effexor is the trade name, and then duloxetine, or it's also known as Cymbalta, are two medications in this class. Main side effects potentially are GI or stomach upset or high blood pressure. Usually for somebody with a spinal cord injury, we're not too worried about you getting high blood pressure, but just something to kind of keep in mind. As I go along, all of them I've included, just so hopefully if you're on these medications you can recognize them. I've put the generic name, and then below that I've put the trade name in italics. So anticonvulsants, folks might think, why am I on a seizure medicine? I have a spinal cord injury, there's nothing wrong with my brain, I don't have seizures. So the general thinking is that they tried using some of these medicines initially for seizures with the thought that they kind of quiet down the nerves a little bit. So in that way, they often will help to some extent with nerve pain as well. So I don't think your doctor's misinterpreting what's going on with you and thinks you're having a seizure, but the medications can have different uses. So the older medications are here, the first generation medications. Those include carbamazepine, or what's otherwise known as Tegretol, phenytoin, or also known as Dilantin, and then valproate or Depakote. These can be effective. The main trouble with these, though, is that they require a little bit more monitoring, lab monitoring, than the newer meds. So all of these have different things. Carbamazepine, you want to make sure your blood counts are staying okay. They can sometimes cause pretty profound anemia. Dilantin has a more narrow therapeutic window, so you got to make sure that it's staying in a safe range. But what are used more commonly, not exclusively, but more commonly, are the second generation anticonvulsants. So that includes gabapentin or Neurontin, pregabalin or Lyrica, and then probably a little less commonly, but still used to some extent, is Lamictal or Topamax. Main side effects with these are sedation, and sometimes people kind of describe a sense of fogginess, sometimes a little bit of dizziness. Most of these don't need any monitoring, and other than the side effects of feeling kind of sedated and sometimes a little bit dizzy, they're usually pretty well tolerated. So NSAIDs, also known as non-steroidal anti-inflammatory drugs, these include things over-the-counter medicines like Advil or ibuprofen, naproxen, or what's otherwise known as Aleve. I've just included a few examples here. This is by no means an exhaustive list of all anti-inflammatory medicines, but you may recognize something that you've tried here. With the anti-inflammatory medicines aren't real specific for nerve pain. As their name implies, they're anti-inflammatories, but often if somebody's got really severe pain, trying to approach that pain by managing it with a few different types of medication that'll work in different ways can be helpful. They, as far as side effects, usually pretty mild and pretty well tolerated. The main side effect is sometimes for folks will cause some stomach upset, and if you were to take way too much for too long, you could affect your kidneys, but that would be more of a situation of taking too much for way too long. And then opioids, or narcotic medicines. So I think probably everyone is, or many people at least, have tried these at least in the time, when they first were injured and were probably still in the hospital. My approach, and people have different kind of ways of managing narcotic or opioid medications, but I usually try to mix a long-acting medicine with a short-acting medicine. So the long-acting medicines that we use, and again, these lists aren't exhaustive by any means, but the long-acting medicines that we use most commonly are methadone, morphine, oxycodone, and fentanyl. Morphine is sometimes called MS-Contin, and oxycodone, the long version, is called OxyContin. So the advantage with these medications is most of them last about 8 to 12 hours. So you're taking them 2, maybe 3 times a day. They'll bring your pain level down. It'll stay down for a while. It'll wear off. You'll take another dose. It'll go down. It'll stick around for a while and then wear off. The shorter acting medicines, and again, this list is not exhaustive, but those are some different examples, tends to give you more of a picket fence kind of pattern of pain. You take it, you feel some pain relief, it wears off in 2 to 4 hours, you take it again, and you're kind of chasing your tail all the time. So what a lot of people I've worked with, and myself included, like to kind of put the medications together so you're getting a longer relief of the pain with the long acting, and then if you really need it, a shorter acting medication for the time that the pain really spikes. So a lot of folks are reluctant to take opioids, and probably for pretty good reason. People, I think, most typically worry about addiction, but I think that there's other things that we sometimes worry about before that. So constipation, a lot of folks with spinal cord injuries struggle with having a regular bowel movement. So to put something else, narcotic medicines slow down everybody's gut. Whether you had a spinal cord injury or not, they're going to make you constipated. But if you put that on top of troubles with your bowel, now it becomes even more difficult to empty your bowel, which most people aren't looking for any more trouble in that way. Before we start worrying about addiction, all people, if they take narcotic medicines for a long time, will develop some physiologic dependence. So that doesn't mean you're a drug addict, but it means that your body has become accustomed to that medication, and if you are on a regular dose of a narcotic or an opioid medication, and you have that stop abruptly, you will have some withdrawal symptoms. So again, it's not that you're an addict, but your body has become kind of physiologically accustomed to it. Certainly, sedation can be a trouble with narcotic medicines. Tolerance, here in the I guess purple circle there, is the idea that you start to need more and more of the medication. So initially, maybe 5 milligrams of one of the medications really took care of your pain, but you've been on that for a couple months, and now you're finding you kind of need 10 milligrams. And then you're on that for another few months, and now you're needing more like 15 milligrams. So people just naturally, physiologically, will start to require more and more of the medication. And then addiction certainly is a concern. That tends to be a situation where you're kind of making poor choices in life to keep the medication going. So we always, or keep that on our radar, because that's certainly something we do want to prevent. As far as topical options, those for some folks work great, and for others are either an irritant or just don't do too much helpful at all. So one option is capsaicin. That's actually made from some of the active ingredients in chili pepper, and it's basically ground up and mixed with a type of cream, and you can apply it to a painful area. I think it probably works a little bit better for more muscular pain than for nerve pain. The trouble if your whole, if maybe your whole lower body is affected with nerve pain, it's not that realistic to smear it all over your bottom half. I mean, it's just not feasible, really. So, so that is, with all the topical options, a limitation, certainly. Capsaicin tends to work better if you use it multiple times throughout the day. Lidocaine is a numbing medicine. It's similar to what the dentist gives you, when you have some dental work done, and gives it to you in a shot form. You can also use that topically, and I have some pictures here of what are called lidoderm patches, or they're stickers with the lidocaine medication impregnated in them. So those can work great. Again, the challenge is they're this big or so, and they're not going to cover your whole lower body. They're also very expensive and not covered by a lot of insurances, so it's hard for folks to get those sometimes. And then diclofenac, or Voltaren gel, is actually an anti-inflammatory gel. And again, it works real well for some things, but if your whole bottom half is affected by nerve pain, it's not going to probably work so well to smear on you from your belly button down. So I'll talk about a few kind of more alternative options. I do want to preface that I am by no means an expert in marijuana, but I'll present a little bit of data and a little bit more information in marijuana therapy. So there have been a few small placebo-controlled studies that looked at whether THC, which is one of the active ingredients in marijuana, was helpful with spasticity. And they did find that it may actually be superior to placebo. So placebo is kind of like a sugar pill. They gave some people the THC, they gave some people the fake kind of sugar pill-like thing. And they found that it may help with spasticity with very limited or minimal adverse side effects. One challenge with marijuana, as far as I think prescribing it and studying it, is that smoking is not going to ever be recommended by anybody medically. So figuring out the right way to deliver the medication, as far as the delivery system, that's pretty important. They've found that the bioavailability, meaning kind of how your body gets the active ingredient out, is not as consistent if you eat the marijuana. And then the doctors aren't going to recommend that you smoke the marijuana. So then they're kind of stuck. How can they actually give it to someone to study it further? So what they've been working on developing is something called standardized cannabis medicinal extracts, which is sometimes abbreviated CME. And so the CME can be administered as a sublingual spray, so that's an under-the-tongue spray. And it apparently doesn't include the psychoactive aspects of marijuana. So you're not going to get kind of more hallucinogenic sort of experiences with it, but potentially would get some of the other benefits that marijuana may offer. So, and there's lots of studies, and we could spend a couple days talking about every study that's ever been done regarding marijuana. So I'm not going to do that, but I'm going to just highlight a couple things. There was a pilot study that was performed in the UK where they looked at the cannabis medicinal extract. And they didn't just study folks with spinal cord injury. They included people with multiple sclerosis, spinal cord injury, people who had brachial plexopathy, which is a kind of a severe nerve injury in your arm, and then people who had amputations and had nerve pain as a result of that. The people had to have neurogenic type symptoms or nerve-like symptoms that were pretty stable, so the symptoms weren't changing all that much, but they hadn't been very responsive to more traditional treatments. They gave the sublingual THC and CBD as cannabinoids, so they gave this spray that they had concocted under the tongue. And what they basically found was the cannabis medicinal extract may alleviate pain, spasticity, and kind of more the infrequent spasms. And then they actually surprisingly found that it may also improve bladder control. The actual outcomes with that were not real specific, so they just said improved bladder control. It may improve sleep and appetite, which improving appetite is kind of good for some folks and probably not so good for others. And then side effects were hypotension, low blood pressure, or sometimes intoxication symptoms. And in this particular study, if someone was developing a lot of the intoxication symptoms, they stopped it. They excluded the person from moving forward in the study. They were really looking for what sort of more traditional medical outcomes or improvements in those kind of symptoms folks could get. And then just a couple more things here. So surgery for nerve pain is not a real common thing. Times that surgery may be pretty helpful is if you have a pinched nerve, so a pinched nerve in your spine, something kind of like sciatica kind of pain. If you have a peripheral nerve injury, so I mentioned the ulnar nerve at the elbow or carpal tunnel syndrome, if you have the tethered nerve roots, so kind of nerve roots that are stuck in a bunch of scar, the surgeons can potentially relieve that or help free them. Or a syrinx, and a syrinx is a cyst that develops in your spinal cord and can sometimes contribute to pain. So those types of things can be treated reasonably well with surgery. The other things that the data haven't necessarily shown as tremendously helpful, but is sometimes done, something called a dorsal root entry zone, or DREZ lesioning. And that's where they actually kind of cauterize or fry the end of your nerve that goes into your spinal cord that conducts the sensations. So they sort of fry that, and then it wouldn't cause pain. Generally, that's thought that the pain that would be maybe appropriate for is more your at-level injury pain. So if you have paraplegia and you have kind of that ring of fire or something right where your injury level is, it may be helpful. I've talked to a couple friends of mine in Seattle who are pain doctors, and none of them know anybody in Seattle that actually does this procedure. So it's certainly not something that's widespread or widely used. A mylotomy is where the surgeon would actually go in and cut your spinal cord. So most people are optimistic that they'll eventually have a cure for their spinal cord or a spinal cord injury or a treatment. Most people aren't going to probably sign up to get their spinal cord cut in half. But it potentially may relieve some of your pain symptoms. It may cause other problems, but that's a possible thing. And then there's always a lot of research going on with stimulation of the spinal cord and the brain. That would be where a surgeon or an anesthesiologist would put electrodes either on the brain or in the spinal canal and actually kind of give a consistent electrical stimulation to that part of the body. The brain stimulation is not really, at the moment, that feasible to have done anywhere outside of the lab or the operating room. So these are things that are kind of still in development and haven't showed tremendous success as far as treating spinal cord injury pain. So acupuncture is one option. It's considered a neurostimulatory technique. I think most people are kind of familiar with the idea of needles being inserted into various depths in the skin and often into the muscle layer. For some people, anecdotally, it seems to work pretty well. The research hasn't really proved that it's effective. But the one thing about acupuncture is there's really no harm in it other than maybe you've spent some time and maybe some money, but there's not really a negative side effect that it's going to create. So for folks, if they can figure out a way to get it to happen, it's often worth a try. So massage therapy. Massage, interestingly, I was kind of surprised by this as I was kind of putting this talk together. There's been a few survey studies. One was performed, actually a couple were performed at University of Washington. I kind of linked them together here. But back in the 90s mostly, there were some survey studies done here where they looked at what were people doing for pain relief. And the two things that amongst two of the things people were doing most commonly were massage and marijuana use. So I think over 50% of the people surveyed were using massage therapy, and I think somewhere over 30% had used marijuana, and they had found that people were using these the most and finding them the most effective. There was also a more recent Dutch survey study, and they found that massage was used more than almost any other treatment. That included medications and treatments other than medications. And folks in general perceived this as amongst the most effective treatments. So, I mean, it really seems like massage is working well for a lot of folks. For some people, it becomes a challenge to figure out how to pay for it, but the data does seem to suggest that people are trying it and people are finding it effective. I think I have 2 more slides, and then I'll turn it over to Dr. Edie. So as far as modalities, again, this is not a comprehensive list, but a couple different options. A TENS unit, TENS stands for transcutaneous electroneural stimulation. So this is another neurostimulatory technique. It basically is giving you kind of little zaps all the time, and it confuses your pain pathways a little bit. So rather than transmitting pain, they're transmitting these little zappy sensations, and people will get some relief. It's usually, again, you can't really cover your whole body from your pain level down. So it's often better for spinal cord injury pain at your level of injury, more of a radicular or nerve root type pain, or more musculoskeletal pain. Heat and ice can be helpful, and probably particularly helpful for folks with more muscular pain or areas of your body of muscular pain. things to just keep in mind is you don't want to apply heat or ice to areas of your body that you don't feel normally, because I have seen folks who have had big burn injuries from a heating pad or frostbite, so you don't want to apply it to any area of your body that you don't have normal sensation. And that's it. I guess I have one more slide. So I'll turn things over to Dr. Edie, and then we'll take questions at the end for both what she's going to talk about and what I talked about.
Good evening. I'm Dawn Edie, as you've heard, and I'm going to be talking to you about things that you can do if you live with spinal cord injury, or if you're someone who has someone you're working with or someone you know who has spinal cord injury, what you can do to help them manage pain. But I want to warm you up a bit to my topic by first trying to stimulate a little bit of discussion, because I suspect there are a fair number of experts in here, and by that I mean that I truly think that if you've been living with spinal cord injury and spinal cord injury pain, you probably have a fair amount of, unfortunately, a fair amount of expertise in what you do to manage it. And so wanted to ask you a couple questions, and I want to preface that with letting you know that for purposes of recording, I'm going to repeat or summarize what the questions or the comments are, just so that they're recorded. But my first question is, how do you manage pain for anyone who has pain here? Yeah. You take a chunk of Tylenol. So you're not afraid of acetaminophen like Dr. Crane was discussing. That's good. What else do people do? Yeah. Distractive activities. Fantastic. Can you tell us a bit if you're willing? So you do something else that occupies you so thoroughly that you're less conscious of the pain. Great. Anyone else use that strategy? Okay. All right. Any other ideas of what people do to manage pain? In the back, the gentleman. Everything you can. Yeah, so it often is kind of a combination, trying different things out. Great, so correct me if I'm wrong, but a variety of things. You said drugs, massage, activity or exercise, and even therapeutic approaches such as ACT, which is acceptance and commitment therapy, and I'm going to talk about that a little bit later on. So it sounds like you found a variety of things helps you out. Yeah, so in combination with other things, but using pleasant thoughts and guided muscle relaxation, which I will talk about a bit more. Well, who do you think is responsible for your pain management? Yeah, who do you think? You are, okay. Who do you're raising your hand? You? You. Who else? I see a fair number of heads nodding. So you think you're all responsible, not Dr. Crane? Great, I'm glad to hear that. You know, I got this slide from a talk on pain management that I have to admit it was based on a study not done in spinal cord injury, but I think it really holds based on my own work and research with people with spinal cord injury, that if we look at who manages pain, it's not Dr. Crane, it's not me, it's not Dr. Goldstein or some of the other physicians. I mean, yes, we play a role in that, but it's really about the person living with pain. You are, as I mentioned, you are the expert, and you are also the person who spends the vast majority of time managing pain. By definition, most pain problems in SCI are what we call chronic. That is, they tend to persist, they tend to be around most of the time. They may come and go some, but they're kind of present in your life. And that means that the vast majority of your time, you are the one who's managing it, and you are therefore the expert on it. And this was based on a study where they looked at, I think it was in arthritis pain, how much time people spent having a healthcare professional such as a physician, that's the yellow slip. Less than 1% of a person who has a pain problem's time is spent having an expert help them out, having them a medical professional help them out. So it's really the day-to-day living with chronic pain is really up to the person living with pain. And so that's why tonight I'm talking about self-management. And what do I mean by self-management? I'm going to give you a really practical definition that I got from somebody by the name of Teresa Brady at the CDC. She's not only a researcher, but someone who lives with chronic pain and has for many years. And she says that self-management simply means what people do on a day-to-day basis to feel better and pursue the life they desire. So, for example, if you like doing this kind of thing, as you see in the slide, what do you need to do to manage your pain so that you can be doing crazy things like that I would never do? How many of you are familiar with the term self-management? Maybe just raise your hand. Have you heard that term, self-management? Or does it kind of make sense, maybe, that you, the self, you're managing it? Well, so what I'm going to focus on tonight then is really talking about what we know about self-management of chronic pain in people with spinal cord injury, as well as just chronic pain in general. And we've been doing research now for around 10 to 12 years, looking at different ways to help people with SCI self-manage pain because of the fact you play such an important role in that management process. Before I talk about specific strategies, though, I want to really, if there's no other points you go away with tonight, I want to really stress one thing. And that is that self-management really focuses on participation. And by that, I mean that the main question in self-management is not how or why did I get the pain. That's certainly important. I mean, clearly, you've had a spinal cord injury, and there are very good reasons to have your doctors or your healthcare providers work with you on trying to figure out what's going on with your problem. But once that's kind of settled, the really critical question is, what can I do to manage my pain so that I can get on with my life? Because we know that pain really gets in the way of people's lives. And so the whole, one of the main goals of self-management is helping people get back to participating in life, doing the things they want to be doing despite the pain. Now, to do that, one other thing I want to point out is that pain management is not just about medical interventions. Certainly medical and rehab interventions are very important play an important role in managing pain. But research has shown repeatedly for more than 50 years now that pain is much more than just a medical problem. It affects people's lives, it affects social relationships, and that social relationships and kind of how people are feeling emotionally or what people do, their behavior also affects how they manage pain and how they feel pain. And that we've called the biopsychosocial model of pain, which is just simply a way of saying that it's really this complex interaction of your biology, the social influences around you, and the social effects of pain, and the psychology, that is, how a person feels and what they do. So with that, knowing that pain is very multidimensional, I want to talk now about some very concrete, practical self-management skills. And glad to hear massage is a popular one. So one way you can do it is to have, your cat massage your back, is to manage pain. But let's talk about some other. But one of the most important things in kind of taking back your life when living with pain is to set a goal. Is to think about, what can I do? What's one goal? It's to take that first step into becoming someone who's managing pain. Now, I'm guessing a lot of you already set goals and are doing this, but I want to call out a bit what I mean by setting goals. And if you're already doing this, you can kind of pat yourself on the back, and if not, it might be a really good place to start. So there are a number of steps to setting goals, and I don't know that we have time tonight for me to go through every single one of them, but I want to point out that you first might want to state your goal. Does anyone here have a goal they want to share related to pain or getting back to doing things, or just life in general? Any of you want to graduate school? Or So you'd like to sleep 4 hours continuously without interruption from pain. That's a very nice, very specific goal. So the first thing you want to do is say, is this a manageable and realistic goal? If you had said you wanted to, create world peace, would that have been a manageable goal? Probably not, at least today, right? But you have a nice, concrete, manageable, and realistic goal. So you will ask yourself, is it this? If not, try to turn it into something more manageable. How confident are you that you can actually reach your goal of sleeping 4 hours without interruption on a 0, which is no confidence at all, to 10, totally confident? I'm going to put you on the spot here. How confident are you can reach your goal? A 5. Okay, what would it take to get you from a 5 to a 6, do you think? Good positioning in your bed so you can stay asleep. Okay. Research has shown that if you have a goal but you're only a 6 or lower on the confidence scale, you're probably not going to succeed. So it's really important to set goals where you feel that you have some confidence in your ability to do that goal. Okay, so if your goal is a 0 to 6, your confidence, it means it's probably too hard. You need to change it a bit. And then this second page would show you some different ways you can list some steps that will help you reach your goal. So maybe your step would be to look at how you're doing your positioning. Maybe a second step would be to get some earplugs if you have a noisy environment and that's waking you up at night, etc. So another easy way to look at goal setting is on this page. Here is just one other way of approaching goal setting that people sometimes find easier, but it's to say, I will, sleep 4 hours a night for 4 hours or for 1 week or for 1 day, on which day or days, at what time or what situation. I feel confident I can do this, and even though there are some barriers that come up, I will deal with them by doing this. So if you kind of fill in this I forget what they're called, Mad Libs or Ad Libs, something like that. If you kind of fill those blanks in like it's one of those, that can help you set a really nice, tangible goal. And a lot of people I work with that have chronic pain feel like pain has taken so much away, especially if they're kind of new in the process of learning self-management, and find that setting a really simple goal can really help you start to take back some power, take back some control over pain. Moving on, one of you mentioned earlier another self-management study that I like to point out, and that's getting active. I think someone mentioned either doing things that distract them or getting active physically. One of the best ways, and this has been validated both in research on pain as well as research on people who are depressed, one of the best treatments is to do what we call activation, which simply means getting people moving, getting them active. Now, getting active certainly includes physical activity like exercise, but it doesn't have to be just that. It can also be increasing your activities that you enjoy, that are meaningful to you, or that simply are fun, that bring you some pleasure. I remember I had one gentleman I was working with who had a very high-level spinal cord injury, and he was really having some pretty significant flare-ups of his pain problem. And he used to love going to his buddy's house and watching Husky football games. And so he really felt that was something he missed, and he could list kind of over time how that took away from not only did he not get to watch the Huskies, but he also didn't get to hang out with his buddies, he didn't get to have that social experience, he didn't get out of the house as much. And so one of his goals was to get active by simply setting it up so that he made a plan to go to his buddy's house, and his idea was he was only going to stay for the first half, and if he wasn't feeling well, his pain was pretty significant, he gave himself permission to leave. Well, he turned out staying through the whole game and then reporting that his pain was actually way reduced as a result of that experience on that day. So that's another way you can get active in addition to physical activity. Or finally, increasing your participation in things that are important to you. So in my example of the gentleman who was a Husky fan, it was important to him to, I think, not only support the dogs, but also to actually go spend time with friends. Friendships were a priority for him and something he valued. So if you're having a hard time thinking of how to get active, think about what you value. What's important to you? What would you, what is it that is consistent with who you are as a person and what you like to do? Now, activation is best, or getting active is best if what you choose to do are what we call antidepressant and anti-pain. So by that I mean, if you're someone who you set a goal of cleaning out your hard drive of all the files you don't need, and you hate being on your computer, that's probably not the best goal. That's probably not going to help you feel a lot better. So you want to choose activities that are probably going to make you feel better and that are going to maybe distract you from your pain, as the gentleman in the front mentioned. You also want to schedule your activities. It's really important to not wait until you feel better, because you know what? You're probably never going to really feel like doing it. If you're waiting till your pain gets better, it's probably not going to happen. So it's important to try to schedule it in just as you would an appointment with a physician, or if going to church or something like that. Schedule it in and do it regardless of how you feel. Getting active is also important if you pace it, if you gradually and systematically increase it, so you don't go and then go out for a whole day if you've been staying in your house due to pain for weeks on end. You need to kind of venture out a little bit more slowly and carefully. And again, you want to get active by setting measurable, attainable goals. And by using an experimental approach, there are going to be times when you try to get active and it's not going to go so well. Maybe your pain's going to get worse. But what you want to do is kind of feel as if you're a detective or a scientist. Kind of go see what happens and notice what happens and see how you feel. And you might surprise yourself in finding that getting active doesn't actually make your pain any worse, or even if it does, the value of whatever else happens outweighs the extra pain. I do want to point out one thing about activity. I see this all the time in people with spinal cord injury and other types of chronic pain, is that people get into this cycle of kind of overactivity and overdoing it. Has anyone here ever done that, where you're kind of having a day where you feel good, or you decide to go do stuff and you do too much, and next thing you know, you really hurt? You've had that happen? Yeah, so you have to watch out for this tendency to maybe get too active, which if you do too much too soon can increase pain and also fatigue. And then what people tend to do is then you're wiped out, so you rest probably more than you need to, which makes you feel less productive, and then that tends to make you feel a little bit crankier maybe, or hurt more. And you kind of feel like you're yo-yoing back and forth between really wiped out or really overdoing it. So you have to be careful with that. And that just goes to my points on this slide, that really pacing yourself is key. You have to look out for kind of triggers when you know you're doing too much, or things that really can be kind of danger zones for you of overdoing it or underdoing it as well, and to try to, again, use time to be your guide. Moving on, another self-management skill that there's a fair amount of research behind is something called relaxation skills. And I think one of you had mentioned using progressive muscle relaxation, which is where you kind of systematically go through kind of scanning your body and in the muscles that you can move, kind of tensing them for a few seconds and then releasing them, and that kind of doing that throughout the major muscle groups. That's called progressive muscle relaxation. But also for people who aren't interested in that, or even just want to try something simpler, you can use your breathing as a form of relaxation. And I've done breathing relaxation with people on ventilators before, helping them to kind of count their breaths or use breathing as a way to develop relaxation. But we know that when the brain is in a more relaxed state, the body tends to hurt less, and it's just also helpful for coping. So I can't even begin to go through all the different kinds of relaxation exercises that are available. I'm going to touch on a few of them a little bit more here in a minute. But I want to point out that relaxation can be a very basic but helpful skill, and give you some resources for accessing that if you'd like to learn that. Anyone here use relaxation in any form? So you use breathing and imagery to take yourself to a different place. Does that help your pain? For a while. A little bit. Okay.
While I'm in that stage.
When you're in that very relaxed stage. Okay. Someone else here does relaxation? You do? Meditation on breath. Good. Okay. So practice is key for relaxation, and so even if you only practice for a very short amount of time, it's kind of like exercise or learning a new skill. You have to use it a fair amount in order to benefit from it. And so I often encourage people to practice it even if you're not hurting, or even if you don't think you have the time, doing it for just a short amount of time. You want to really develop it so that it's a habit. That's how it's going to be most useful to you. So you want to use it whether you're stressed or not, whether you're in pain or not. And there's a variety of ways you can learn relaxation skills if you're interested. On this slide, I have 3 different websites where there are free downloadable audio files. I think these are all audio files, and I vetted them. They're all really good relaxation skills that you could try out. There's, many, many different kinds of relaxation skills. Also, there's one on your smartphone. If you have a smartphone or web-based, there's one, for example, called Breathe to Relax. It's a free app that you can use that'll talk you from, it assumes you're naive, you've never done relaxation. It'll talk you through how to practice breathing relaxation. So that's also a nice way to learn some relaxation skills. And again, free of charge. Now, how many here have tried hypnosis or self-hypnosis? Anyone? Few people have. So hypnosis, or sometimes its more fancy name is hypnotic analgesia, can also be very useful for managing pain. We've had several studies here at the University of Washington by my colleague Mark Jensen and others looking at hypnosis, and we found that about 1/3 of people with spinal cord injury pain actually report that hypnosis is very helpful in reducing pain and its effects on people. About another 1/3 say it helps some, and another 1/3 it doesn't really help very much at all. So it's hard to know if you're going to be someone who benefits from it or not unless you give it a try. And by hypnosis, it's really just a state of focused attention and relaxation, being very present in the here and now, and kind of using imagination in a way that helps you really have this very relaxed state. And then through that, having some suggestions for decreasing unpleasant experiences and increasing comforting or comfortable experiences. Someone also mentioned mindfulness. I think you mentioned you do maybe some mindfulness meditation. That's also very useful. And here is, on this slide, I have a website where you can learn more about it. There's some nice self-help books. There's tons of resources on the web, in the iTunes store, the Droid app stores. And mindfulness is really simply being aware of the present moment consciously, so deliberately trying to be aware in the moment and having a real kind of focus and non-judgmental attitude towards the moment. And so it's a way that people can kind of learn to be more present in their life. And some people find it very relaxing, some people find it very helpful. I'd be happy to answer questions about it later if you have them, but this is an approach that's being used a lot for people with chronic pain. Just a few more slides. I want to point out that depression and pain often go hand in hand. Not everybody who's depressed has pain. Not everybody who has pain gets depressed. But oftentimes about 30 to 50% of people with one or the other have the other condition. And interestingly, it used to be thought, oh, you know, depression causes people to feel pain. But actually, research has now shown that living with pain is a risk factor for getting depressed. And not everybody, again, who has pain gets depressed, but often pain precedes depression in people rather than the reverse. So it's really important if you notice symptoms of depression, feeling down and blue most of the time, having low energy, not wanting to get out there and do things or be with others, that you may want to see your doctor and see if you might be depressed and seek treatment for that. And on that note, self-management sometimes includes asking for help. So certainly, even though managing pain is something you are primarily responsible for, there's also help out there, and sometimes part of managing it is asking for that help. And there are a number of treatments that can be used, oftentimes delivered by a mental health therapist, a psychologist, nurses, occupational therapists, physical therapists as well. A number of these kinds of treatments are available to you, but unfortunately they very rarely do people with spinal cord injury get access to them. So things like cognitive behavioral therapy or CBT for pain, hypnosis, as I mentioned, acceptance and commitment therapy, meditation, yoga, etc. So if you're interested in that, I'd be happy to answer questions about it later. Also in my slides, I have some more information about it that I put in my slides. I won't necessarily go into a lot of detail, but I wanted you to have that information. For example, CBT, it's a type of behavioral or psychotherapy where you help people learn thoughts and coping skills for managing pain that can help people not only reduce their pain, but feel better and do more and function better. So that's just one type. Or someone earlier had talked about acceptance and commitment therapy, which is focused on something called pain acceptance, which people sometimes think, why would I want to accept pain? But it has to do with sometimes when we give up control of something and decide we're not going to try to control something, we actually can have a certain freedom from that. And so pain acceptance has to do with allowing some pain some of the time and just being more kind of aware of it versus fighting with it. And the reason I bring this up is that acceptance and commitment therapy is a kind of a newer therapy for pain that's gotten a lot of, has some science behind it to say it can be very useful. And research has shown that people who can kind of have this acceptance of pain tend to have report less pain intensity, less distress, and that they just aren't as aware of their pain, and that they tend to do better physically and emotionally. So again, I'm not saying I want you to all go home and accept pain. That's not what I mean at all. But it's a type of kind of mindfulness approach to being aware that pain is there, but that it doesn't necessarily have to be something you fight with all the time or that has to kind of rule your life. Lastly, I have a number of pain self-help materials on your slides. These are some books. I have to confess, none of them are written for people with spinal cord injury pain or even people with neurologic pain, but a lot of the research suggests that the strategies in these books are also very helpful for people with spinal cord injury pain. And there's even some online self-management programs. At Stanford, they have a program called Better Choices, Better Health. It's a chronic disease self-management program that addresses a number of chronic conditions, including chronic pain. Again, not specific to SCI, but I think something that could be very useful if you want to learn more of these self-management studies or strategies. And I think that it's free of charge or very low cost. So you can go to that website to check out more. There's also more listed online pain management programs at this address as well. And with that, I'd like to thank you for your time and attention and mention that if you have interest in learning more about pain, the Model Systems website has a ton of great resources. The newsletters have great resources on the topic of pain in spinal cord injury. Yeah, so the suggestion was another book, which I'm aware of, and it is a great book. It's by Steve Hayes, and it's called Get Out of Your Mind and Into Your Life by Steve Hayes. H-A-Y-S, I think, E-S, H-A-Y-E-S, and the point was that it's not only useful for pain, but could be useful just with other common things that we humans experience, right, like stress and other things. So, thank you. Questions?
So the question was, I think in case anybody couldn't hear, was do homeopathic techniques such as applying perhaps even a more severe pain or applying a pain in the same area that you are having pain help distract from the pain that you're experiencing? Did I rephrase that? Okay. You know, I am not by any means an expert on homeopathic techniques. I think the example that you gave, sir, may work similarly to the way a TENS unit that I described may work, that you're kind of confusing the pain receptors a little bit, and they're busy interpreting, in your example, that scrubbing sort of discomfort, and then while they're busy doing that, they're sort of tricking you that you're not experiencing the pain that you otherwise normally feel. So I think that's the best kind of idea that how I could link those two together. So, you know, I think as long as you're not causing trouble to your skin, if that technique works, I don't see any harm in it. But I think it's probably working with what we sometimes call the gate control theory, or the way that sometimes pain receptors can't handle multiple signals at once, so they get sort of overridden by perhaps one stronger signal.
The question was, how might I suggest a person find someone they could work with who would help them learn things like relaxation or hypnosis? I don't suggest going to a bar and getting up on a stage with a hypnotist on a stage. I suggest that you look for someone who has maybe some experience in using hypnosis, if that's the treatment you're interested in. You know, someone who maybe has done work of pain control with hypnosis. It doesn't require necessarily a certain type of care provider. I mean, certainly a lot of psychologists know it, but other healthcare professionals do too. If you're local and you're interested, we have a couple studies, as I mentioned, so that might be one way, or talking with your doctor if they have any healthcare providers, they can recommend that do hypnosis. Those are some of the ways I'd recommend. Certainly the relaxation, you could certainly go see a counselor or a healthcare provider to help you learn that, but I would encourage you to try it out on your own through some of the resources I provided as well. Or support groups or other places people can sometimes, or disease self-management groups such as the online ones are things you can maybe learn some of those skills. And I'm open to other ideas or suggestions as well for that. Oh yes, okay, the question was that Dr. Bombardier has heard that smoking can exacerbate neuropathic pain, and wondering our thoughts on that. I can't necessarily speak to the mechanism myself, but I know that there's research going on at the University of Alabama, and I think another place, looking at helping people to stop smoking as a form of pain management or pain treatment, and that the preliminary results that I'm aware of at least suggest that actually stopping smoking can actually improve pain.
And I guess just to touch on the idea, perhaps some of the mechanism is that nicotine and smoking and nicotine cause some constriction of the blood vessels that supply all of our body tissues. So when you're smoking, you are causing that constriction, and you may not be getting as much blood supply or oxygen supply to any of the body tissues. And so I think that may be one way that whether it's nerve pain or other types of pain, those tissues are at least temporarily deprived of nutrients, so that may exacerbate pain.